How you doing? I'm Jay Ladde. I'm actually from Orlando. I'm at Orlando Health. I have no financial disclosures. I think probably all of you have probably taken care of maybe an abscess or two during your careers. Hopefully you have. If you haven't, this will be a very interesting talk for you. To give you a little bit of background, there's about 3.5 million visits per year in the U.S. for abscess and skin and soft tissue infections. That number is from 2005. Literally 8 years prior to that, there was about 1.5 million. That number jumped up, and the real reason being is 80% of that 2 million jump are from skin abscesses. What are the most common causes of skin abscesses? It's methicillin-resistant Staph aureus. I think all of us know that. It's about 63% of your skin abscesses. Actually, in our community here, we see 85, upwards of 90% of our skin abscesses are MRSA. So we haven't cultured an abscess probably in 15 years or so. I'm giving away my age, I guess. The other 15% or so are MSSA, and then you have a small amount that are beta hemolytic strep, like 1 or 2%, and then there's various other bacteria that cause these infections. So moving forward, it's sort of important to grasp ways of taking care of these abscesses. We know that we're not always great at identifying abscesses. There's a study that looked at cellulitis. The ED physicians had described as being cellulitis. They threw an ultrasound on them, and about 30% of the time we were wrong, and there's actually an abscess there. So again, taking care of abscess is a very common thing we do in our ED, and something we do every day. So we have a gold standard, right? There's a lot of things we do in medicine there is no gold standard for. Gold standard is incision drainage and packing. I mean, I think we've all done this. It's pretty brutal. I don't know when this was created. It's probably from 1700s. This procedure is still done today, basically the same way it was done for the last 100 years. Over the last 10 years or so with the advent of MRSA, there's been a lot of procedures that have been described in the literature to sort of get away from the standard packing technique. Some people have ascribed to the fact that you can not pack these abscesses, size and drain them. There's a couple of studies out there, and basically they have conflicting results, very small numbers, probably not enough to change practice. There's a study in Annals that looked at using ultrasound to poke a needle into an abscess, drain it, aspirate it basically, and compared that versus packing. And they found that 26% of the time they're successful with the needle drainage and 82% of the time with the packing. So again, not useful enough. When they failed, it usually was MRSA abscesses. So again, in our community and most communities, it's probably not the optimal way to handle these things. We've seen things like warm compresses, EMLA being used to kind of get spontaneous rupture on small abscesses. But again, none of these things have taken over our gold standard incision drainage. So before I go into how we do the loop and why we do the loop, I want to tell you that we started doing this in about 2002 at our children's hospital. Our pediatric surgeons started doing this, and we started doing this about simultaneously. Within 3 or 4 years, it would be done at our level 1 trauma adult hospital as well, as actually most of our community hospitals in the area and most of the state do that. I think it probably has something to do with a lot of our graduates being in those hospitals. So let's talk a little bit about the technique. There are videos online and so forth you can watch. This is a very simple technique to learn. Our extenders do this, students do this, residents, even us old attendings do this sometimes. You have this is a pretty simple skin abscess. This is the area of erythema. This is probably about 2.5 centimeters on a child. This child is sedated. You want to prep your lesion like you normally would. We're using the blue towels for a little bit more prettiness. I'm sorry this doesn't convey as well on this projector. You want to anesthetize the area, whether local or, in our case, we did sedation with local. Use an 11 blade, cut about a 3 to 5 millimeter incision. Push your forceps through, break up the loculations like you normally would do. Tent the skin up at the polar opposite end of the abscess. Use the 11 blade again, make another incision. Pop the forceps through, or needle driver actually. Grab the vessel loop, which can be found in most ORs of your central supply. Pull it through. Now you want to irrigate the wound out very well, just to get all the pus out and get all the debris out of there. Tie it down. Don't secure it too tightly. I usually leave about a finger's breadth worth of space there so it can move around freely. So when mom's cleaning up the wound, she can move it around and and if someone's sitting on it or something, they can move it and it's not so uncomfortable. That loop will stay in there 7 to 10 days. It's very simple to remove. You just clip it, somewhere along the band and remove it. Parents do this, patients do this. They can come see us. We'll take care of it. It's an easy thing to do. So is it efficient? Is it effective? We've done several studies on this, and we have some prospective stuff coming out, so I can't speak on that too much. But this retrospective study showed failure rates is about a 7 times failure rate in pediatric patients. The loop outperformed incision draining. Again, the odds ratio showed a predisposition for the loop technique being better. In looking at ease of procedure, physicians, extenders who are doing the procedure rated it as being roughly equivalent to packing technique. Patients rated it as being much easier to take care of. Makes sense. You don't have to have another packing put in. You don't have to worry about pulling it out or accidentally knocking it out of place. It's easy to clean, easy to move around again. When you talk about pain, it actually is significantly less painful initially, and when you're looking at over the next 3 days, it's a lot less painful for patients. Some of the pitfalls are that you have other physicians that may not understand this technique, so make sure your surgeons, your community physicians understand what you're doing before you do this. It's easy to perform and teach. It's alternative, yet equally effective management of skin abscesses, and I think in pediatric populations you'll see that it's actually probably a better technique. So just loop it. Any questions?